Good morning, staff and my fellow. I'm Dr. Panit Tungbanjerdsook from Thammasat University Hospital. Today I'm gonna talk about the complete radial tear meniscus and how to deal with the nightmare. First, I want to thank to all my professors for good advice. Here is the outline. Okay. The radial tear seems to be easy, but it's actually difficult to manage. The radial tear account for 15% of the whole meniscus tear, and the tear is perpendicular to the circumferential fiber. The tear from this review is about the failure rate is about 20% compared to the other types. As we know, as the radial tear occurs, the circumferential fiber would act as a hoop state will lost, and devastating the biomechanics and increase the contact pressure. For the medial meniscus, we can see the radial tear in a chronic injury, old age, and located at the posterior horn, and we can see a more cartilage damage. In contrast with lateral meniscus, we see in the acute injury in younger age and located most in the body and associated with the ACL injury. DMI, we can show the clip sign, gold sign, truncated, and sometimes the meniscus extrusion. If the radial tears occur at the body, the gold sign will be on the coronal, the clip sign we see in the sagittal. And if the posterior horn was tear, the clip sign will be on the coronal and the sagittal sign, gold sign will be on the sagittal. And here, sometimes the axial cut could help you see the tear. The problem of the radial tear is that it alters the biomechanics of the knee. From this study, the complete radial tear increased 49% of the contact pressure and decreased 47% of the contact area. Moreover, from cadaveric study of Bashi show that 90% circumferential radial tears increase the contact pressure and decrease the contact area, while the repair group decrease just only contact pressure. And also, the partial meniscectomy doesn't change the area of the contact pressure compared to 90% tears. This emphasizes the role of the repairing the meniscus. Another study from Dashi also, but in the medial meniscus radial tear, showed that even in 90% of the radial tear, it did not change the contact pressure compared to the low-grade tear, like 60% or 40%. But the partial meniscectomy changed this biomechanics. So this shows the importance of the remaining 10% of the peripheral tissue that you should keep. The partial meniscectomy only improve the outcome just only the short term, 3 to 6 months, but it will be plateau at 24 months. But the repair, we improve the linear curve even in 48 months. And the consequences, the radial tear, if the large radial tear occur more than 1/3 of the circumferential, there will be like a occasion to occur the meniscus extrusion, and the OA change will be 28.6%. And even if there is a radial degeneration of the meniscus more than 1/3 of the circumferential, the osteoarthritis will be increased to 43.8%. Now, if the occur of the extrusion and the progression of the osteoarthritis of the radial tear, so we should try to repair it if possible. But the problem is that the healing rate of the radial tear from this systematic review show that it's very vary. In a complete heal is 60 to 100% and failure rate is 0 to 30%. The possible risk factor is that there's no ACL involvement and old age has an OA Kigerorin grade 1 and the tear is located in the medial meniscus and the female, and also the technique that do not use the transtibial repair. So which technique should be used to overcome this problem? The repair technique has so many, like a capsular-based, meniscus-based, and a transtibial. And also the approach. The approach has all inside, outside in, inside out. You can use it depending on the location and the type. And also the configuration. From this systematic review in 2023, there are so many configuration sutures that we can use to overcome the problem, like a inside out double horizontal, or inside double vertical, or inside suture anchor, rib stop suture, cross tack, and even transtibial, and combined with all inside the both vertical and horizontal, and also the hybrid transtibial. But which one is the best? From this systematic review, they compare 20 of the study about the surgical technique to repair. Comparing inside out and all inside, they suggest that you should use the all inside figure of 8 combined with the one vertical. They will have the better biomechanics compared in all inside or vertical and inside out horizontal like the traditional way. And inside out versus inside out itself, they show that if you add the parallel suture like a rib stop or the rebar technique, will prevent the suture to cut through and has a better biomechanics compared with the technique that do not use. And all inside versus all inside itself, you should use the suture base better than anchor base and should add some oblique suture or the rib stop as well. In the transtibial, you should add the transtibial combined with the inside out or all inside technique, like a Laplace proposed, like this transtibial tunnel plus 4 horizontal inside out suture, which has the best biomechanics compared to other technique in 20 studies. And also in 2023, there's study about the biomechanics of all inside repair. They show that the oblique block and rebar stitch has a better biomechanics compared to double vertical and double cross. This emphasizes the role of the suture that parallel to the radial tear to prevent the cut through and tissue failure. In 2024, they studied the failure rate of the all inside compared with the inside out. They show that the inside out and all inside had a good favorable outcome, but the failure rate is higher in the inside out group. This also related to the previous one that the all inside has a stronger biomechanics. And lastly, George and Laplace proposed a classification that guide the treatment, divided into 5 types: the partial tear, white zone, partial tear, red-white, complete tear with no gap, complete tear with gap less than 3 millimeters, and complete tear with gap more than 3 millimeters. The first type, you can use the partial meniscectomy in the white zone, and the red white zone partial tear, you can do just only the side-to-side repair. But in complete tear, you should use the hashtag. And if the gap less than 3 millimeters, you can add the reduction stitch to help reduction and use the hashtag suture. And if gap more than 3 millimeters, you should can release some of the capsule and reduction stitch and use the hashtag. If you want more biomechanics stronger, you could add the transtibial tunnel. So, in conclusion, the technique you can use has a favorable outcome depending on location and tear type. The traditional inside out, you should add the parallel suture like rib stop or rebar. Or inside, you should add the vertical suture, rib stop, oblique suture, and use the suture base more than anchor base. The transtibial suture combined with inside out and all inside would get the better biomechanics. Another small detail is that there is a study of the biomechanics of the peripheral suture compared to the inner suture. They found that the peripheral suture has a higher load to failure, which is stronger than the inner suture. The author suggests that when you try to repair, you should use the peripheral suture to tie first to prevent the inner suture to be cut through. And also, like a material, this study showed that the material of the tiger wire, tiger tape, and the rebel tape compared to other like a fiber wire, this three has a better load to failure and the stiffness. Apart from the technique, there's also the biologic augmentation. All the biologic augmentation, there's no inconclusive point to this. Like definition is easy, like a penetration to the red zone to create the channel of the blood supply, but it's contradictory evidence, so we used to combine with the repair technique. Also the abrasion, we could use the lash to create the raw surface, and also it's good healing in the human trial. The microfracture, mostly the study is associated with the ACLR, so they see the pro of this microfracture. But in one study showed that the 2-year follow-up, there is still 41 unhealed. So this systematic review still contradictory result. PRP gain more popular. There's also in the mixed result in the meta-analysis due to the result and also the no standard in the dose and the formation. So there's insufficiency to recommend the use. The farbin cost as well as the PRP is easy and less expensive, but also the report is still inconclusive. So there is no definite conclusion to recommend. Another problem is that the extrusion reduction can help preventing the OA and the higher rate to turn to the arthroplasty. In transtibial, you can help centralize and reduce the contact pressure, improve contact area, and also preventing the progression of the arthritis. And also about the HTO. The HTO more study focusing on the root tear, but from this study show that not only you correct the malalignment, but you also help to reduce the medial meniscus in 12 months of the follow-up. The rehabilitation in the meniscus has a restrict protocol, the delay, range of motion, weight bearing, and return to sport. And the accelerated protocol that you can use immediate range of motion, shortening the brace, early weight bearing, and more return to sport quickly. But in the radial tear or the root tear, the biomechanics was changed. So the rehabilitation is very in protocol, but usually delay in range of motion, weight bearing, and return to sport. This from survey of the American Orthopedic Sport Medicine. In the radial and the root tear, they will delay the weight bearing and full range of motion and return to sport. The range of motion, they can start 0 to 90 degrees in the post-op, but delay the full range of motion until the 6 week, and the weight bearing will be protected until the 6 weeks, and return to sport will be 6 months. In conclusion, like we know that we lot of hoof stress, extrusion occur, and progression to the OA, so we should try to repair if possible. The technique has a favorable outcome, but if you use the traditional inside out, you should add a parallel suture. If you use the all inside, the vertical suture, the stop oblique suture, and the suture base will get a better biomechanic. And also the transtibial combined with the inside out and all inside. The biologic enhancement, there's no conclusion, but suggest to use like an augmentation of the repair, and especially in the like a not good tissue. HTO can correct malalignment and also decrease the extrusion, and rehabilitation should be delay the full range of motion, the delay in weight bearing, and return to sport. Thank you.